30 minutes, one question, one follow-up, and I'll turn it over to Dr. Williams now.
Yes, good afternoon. And I'm here today. Dr. Yaffe's off at other meetings, and I was off at other meetings yesterday. And so we're doing trade-offs as things are getting busier on all different fronts. And it's only a matter of efficiency, who does which one which day. So with that in mind, we are into another period of time in my mind. Yesterday was the sixth 14-day segment that we've completed throughout this time. And I do that because 14 is the incubation period, and you've heard different factors in WHO reporting that. It's more important that we finish the 3 two-week periods that we did since we started closing things down with the March break, etc. And as I said before, we wanted to see in the last one how well did, with the travel exposure being reduced to pretty well negligible, how well have we done with our public health measures, and have we made an impact, and have we been able to bend the curve and be successful in that. And as you've heard, Monday, the team are going to talk again about the revised, updated modeling, and we're looking forward to hearing that to see how well have we done. Where are we projecting now? What should be our focus now and our issues now? And I think it's going to be informative. And as I said, I think for Ontarians, you're going to hear that for some aspects, we have done well. So Ontarians, you have done well in that regard. So far, we now have to keep our visions for the next 2-week period. And what is the next 2-week period? And I'm going to talk about that when I get through with the numbers and how we're going to watch this and how it will transpire over the next while and how that's going to drive in decision making as we progress and go ahead. So looking at the numbers of where we are, and of course we have, the global numbers. More of concern to us is what's going on just south of the border, and as they're putting up a very valiant effort there, looking at now deaths over 37,000, over 710,000 cases. So those continue to escalate and moving sometimes from one state to another. That means we do have a lot of activity just across our borders, and we'll be continue to be concerned with that as we go forward into the next number of weeks, if not months, into the springtime, as we watch that even further. So keep that in mind there. And other provinces are progressing with some of their numbers dropping. And it's informative to look at those numbers because where are they in their curves? As you know, some of the numbers seen in the West are somewhat smaller than ours, and that's only understandable because some of those provinces have only a quarter of the population of Ontario, and certainly less than Quebec as well. So it's a matter of numbers and how that is doing, and how do we compare in that, and how are we progressing. If we look at the cases and the numbers for today that were done yesterday, we've got to keep that in mind. We now have 10,010 confirmed cases. So we are on over 10,000 in Ontario reported through the Integrated Public Health Information System. And I'll talk about why those systems and different numbers in a moment here. We had an increase of 485 confirmed cases. The demographics are similar to what we reported in the past, and still the Greater Toronto area has over 56% of those cases reported in there, and we still have that trend direction with more females being reported in males in the overall data, and some that feels to be part of the workforce, etc. in that regard. We have on the IFAS system reported 36 deaths with a total now 514. And so those are the ones reported in through the public health system that have had all the data points fulfilled and are clear in there. We're going to give you some different numbers as reported by the long-term care and some numbers there, and I'll talk about that in a moment. So we have 108 outbreaks reported through the IFAS system in the long-term care homes, and those are the ones that have completed all the aspects in a outbreak management system there, including not only the possibles but the confirmed ones and they've just put down the confirmed ones. In the long-term care, they are off the mark with 127 reported, and a number of those are those very early symptomatic ones that are noted as well, and that means the actual integration of the I would say the epidemiological data, as it gets in and completed, is then put it into the IFA system. So there's the administrative data, and then there's the epidemiological data. Not trying to confuse you, but they serve different purposes, and they're both correct in their own ways. In that, if we look at that, we also see that our resolved cases in the overall population level is 4,875. So a number of people going back weeks that were coming from the community that have been assessed are recovering and getting better. And so that represents nearly 50% of our cases. So that's a good news point there. Our healthcare workers, we have positive 1,139, and unfortunately now we've had our first death related to a healthcare worker, and that is always very concerning, and we need to watch that. Not that any death is not concerning, and we are continuing to monitor that situation, and of course the condolences to not only the institution, the family, because I understand the person was a long-term dedicated worker of that institution, and not to be taken lightly in that regard at all. Our ICU numbers in that are pretty well staying stable, with the ones in hospital around 828, our ICU about 250, up a little bit more, our ventilation ones down 197. And we keep getting asked questions about how many people recover in that aspect there. When you get death data from individuals from the hospital, that's from the hospital totally, whether it's in the emerge, on the ward, in the ICU. So we don't get that detailed breakdown in unit by unit per se. We could, but that's not normally how hospitals collect that kind of data. So we're continuing to try and ask some of those questions, because what they're using that for generally with ICU and ventilators is more the clinical people comparing what is working from a clinical intervention standpoint. Is this better than that? And that's a discussion they need to have, and I'm glad they're having that, because all our scientists and our top clinicians are having those discussions as they deal with the issue here in Ontario. How does they deal with their peers across Canada and internationally with this new novel coronavirus? So going back to our numbers there, as I noted there, we had the 485, and that's made up of two groups, and I'm going to get more complicated as we go forward. It may have and potentially three groups in there. So the 485 is the total number in the Integrated Public Health Information System, which is made up of the long-term care data and the ones from the community. Our laboratory does those tests and reports the specimens in. By the way, the laboratory tests that we were able to do yesterday, the total of all specimens sampled is up again to 9,462. So we continue, that's our highest amount in one day, and that's progressing. Those are specimens. In the long-term care side, they reported that they had an increase of 147 residents and 80 staff. So that means their total was 227. If you take the other one away, that gives you 258 that came from outside that, potentially, knowing the numbers are not exact down to the hour and the minute. So my sense is that gives you an idea that half our cases are community and half are long-term care, whereas on Thursday, more were from long-term care, and you're going to see that trend continue. It tells us that our community ones have gone over the peak and are coming down, and we'll hear more from our modelers. But in mixing that is a very enhanced long-term care testing strategy that we started rolling out on Wednesday, Thursday of last week. And remember, these samples you're hearing today were received on ones we did today, were analyzed yesterday, were received on Thursday, and the test was done earlier. So we have a bit of a delay of when these ones were presented to the cases in the community. So we see this shifting trend, and that's encouraging. To me, that tells us that our social distancing, physical distancing, has and is continuing to work. Nevertheless, I'd like to see that number from the mid-twos, because that's where we were about almost 5-6 weeks ago. And remember, we used to be down in the 100s and getting below 100. It would be nice if that community number could keep dropping down and push that below 200, down even below 100. Much like the similar, if you take BC, they're in the mid-20s, 30s, but you multiply that 4, because of the population size, we're somewhat in that range we need to get to. So I would still say we have to continue our physical distancing, social distancing, but we may be able to look at it in a bit more of a cautious way as we go forward. And I'll talk about that in a moment. So that number's coming down. We are also undertaking at this time, over this weekend into early next week, and some on Thursday and Friday, to do an intensive survey by public health, working with the long-term care facilities, to do surveys of whole institutions to say, what does it look like? Are there a number of people who are asymptomatic there, positive, residents and staff? So that data will start flowing in as well. And so you're going to see almost a survey of long-term care, the ongoing outbreak management of long-term care, and the community side. So for the people who like the data, it's going to be a little bit more complicated to interpret, but in a way you want to say, what does it tell you is going on? What's going on in the community? What's going on with all these outbreaks in long-term care homes and retirement homes in the future? And in a sense, what's going on in long-term homes writ large with your survey? Each one of these data systems are there to tell you what's going on, to test a hypothesis, and to give us indications and direction of how our policies and our interventions should be the same, should be changed, should be enhanced, and that's why we're moving ahead with a lot more enhanced work in our long-term care facilities. So that's the numbers and the aspects for today. And people are asking, so what can we expect? We have the modeling report on Monday. We're going to be asking, we're having discussions now with our public health measures table to say, when do we start to ease off some of these ideas and directions? How do we ease off those? Do we totally ease off? We said before, we turn the switch up. We're not going to flip it right off. We're going to turn it back. But how do you do that? To maintain the aspect of keeping it under control, that you don't rebound. And so we're going to be doing that, talking with our scientists, talking with our data people, and talking with the business economic side to say, how do we get things moving back up with caution? So it's going to be a lot of yes, but with the following caveats. So stay tuned, and we're going to give you some more information as the next week goes out. That's what the next 2 weeks are about. Continuing to make sure we're doing our distancing, get those numbers down if we can in the community, below 200, start to work out aggressively at trying to bring our outbreaks and long-term care under control and modify that. Look at our retirement homes, get on top of that, and our other congregate settings and other risk populations. So the tasks are serial, and we have to keep working at it. So with all that explanation, I'm going to hand things over to the media and ask for questions. Thank you.
Okay, we'll move to the phone lines.
Your first question comes from Carrie Virama with CBC News. Please go ahead.
Hi there, Dr. Williams. I want to start on the long-term care. You said it's going to be a focus to try and contain the outbreaks over the next 2 weeks. We continue to see the number of facilities with outbreaks increase. I recognize that you do have a liberal definition of what constitutes an outbreak as a proactive measure, but we're hearing from the Ontario Nurses Association, the union representing workers at Eatonville, for example, talking about how management is not taking your directives and that they have lost faith in the management's ability to contain the situation. How concerning is that for you as Ontario's Chief Medical Officer, that your directives are reportedly not being executed in long-term care facilities where there are outbreaks?
So what we ask and what we're doing with our command table is that we have the directives out there. We're asking for our public health units and also the ministry with their inspectors to say, how are all the nearly 300 long-term care homes doing? How are they prepared to do all the aspects in the directives? I get a sense, I'm saying we'd like to, but there are some limitations with our staffing, with equipment, and with information that we really can't do them all. Therefore, then we're doing that assessment to say, how do we move alongside you so that where you were not able, we're going to make it that you can be equipped and so you can prepare in the event you might have an outbreak or even prevent it altogether. So you have a variation in capacity and ability, and so we're trying to move alongside that to ensure that we can ramp that up and deal with any diffusal situations. In the sense when we've done things so far, I haven't had anyone saying we're just not going to do it. I think what we're trying to really understand if there's a systemic problem or there's an institutional problem Is it an unwillingness or an inability? And we're finding a lot of it is inability because they haven't got the resources available to them in their mind. They are stretched already with dealing with it, and sometimes their staffing is stretched, their supplies and their testing capacity and their expertise and knowledge of how to carry out infection prevention control needs to be ramped up because they normally do not have that in their facilities at that time. And the public health who's supporting may have 7 or 8 or 9 or 10 outbreaks, so you can only stretch so far. So we have a system-wide assessment going on and a system-wide investment of how we're going to do that to bring these outbreaks under control. So I have not heard that there's any just not doing it. I am concerned that some said we're just not able to do it, and therefore we have to help them to be able so that we can protect these individuals and these institutions to limit outbreaks and to prevent them altogether.
Follow-up?
And can you elaborate a little bit on what regions you're seeing, or if you can kind of paint a bit of a picture out of the 300 that you talk about, how many of them are coming back and saying we have difficulty to adhere to these because of things like staffing issues or legitimate issues, that it's not like an allegation of negligence by any stretch, but more just a realistic feasibility for them? How many LTCs are actually reporting that back to you?
So we're trying to meld our data from public health with that of long-term care inspectors and saying is like an assessment, and then saying, okay, then we go and talk to them and saying, here's how it looks like there, and to go through the steps of the directive, how you doing this, how you doing that, how you doing this, not from a sense that's going to be judgmental in that sense, but saying it's like an assessment. Can we help in this way? Can we help in that way? Is this okay? Is this not? So we're taking that original survey, we're adding to that probably hoping to have an on-site quick assessment phone call and discussions, and then to see how quickly we can move in to mitigate any problems or issues as quick as we can. So it's a dynamic, ongoing process as we speak, and it's not just clustered in one area or another. There's different types of institutions. We have a broad spectrum in size, broad spectrum in age, broad spectrum in different capacities, so it's not a cookie-cutter approach.
Next question.
Your next question comes from Janice Golding with CTV News. Please go ahead.
Hi. Following up on Kari's question, this was posed to the Premier earlier. We wanted to know, Dr. Williams, under what circumstances will the province step in and take control of long-term care homes that are seeing massive outbreaks?
So our position, because the long-term care homes are either not-for-profit or for-profit type organizations, and they have various contracts with the Ministry of Long-Term Care. What we've done historically all along, when we have these issues, we move alongside because we have our local public health is involved, and what we're asked them to do is to undertake various steps to mitigate the outbreak. And if we see issues that are concerned, then we request the institution to deal with that within their own resources. And if we don't, then we can say, okay, we can assist in this way. We make it very strong recommendations we have to. And local medical officers of health, if they need to, can write orders if there is some resistance to those issues. And we don't really see that too often. Most I find is that they want to deal with it, they want to work with it, but they're not sure if they have the full resources at hand to deal with this very unique and very challenging novel coronavirus. And they're looking to say, how do you help us, and how can we get on top of this? Because we want the best for our residents, we want the best for our staff, but this is a new thing for us. And so I find it's not so much of taking over, but coming with something to assist, whether it's personal protective equipment, swabs and testing, human health resources, or the alignment of staff and where you put the patients and residents to deal with better infection prevention control practices. So we just have to make sure we're ready to move in alongside that. It's not a matter of a takeover type stuff. It's a matter of all hands on deck and doing what you need to do to get the best out there for this sector of our population. And retirement homes are different, but that's a different area we're working at as well as other congregate settings.
Follow up?
Okay, and then secondly, the City of Toronto senior staff met today to discuss restart and recovery planning the consensus was we're far from ready to reopen. The Premier was posed the same question. He says they're waiting for the Chief Medical Officer of Health, which would be you, to give him the green light, but he says this is going to be methodical. We're just wondering if you have any idea as to a possible timeline, given, for example, the City of Toronto is saying the best case scenario, it's going to lose $1.5 billion in revenue this year.
That alludes to what I said during the introduction, is that as we are now coming down, we're going to hear the modelers on Monday. We're going to get some projections from them. Remember, they were projecting that we would be at a peak with our hospital services, critical care in that aspect sometime in this past week, and we'll see how that evidences itself out. They said there could be some other peaks coming up, so we want to see where that is. Why that's important, and you're correct, the economic impacts, not just City of Toronto, the province and Canada and globally is immense. And so how do we make sure that when we can allow those things to ramp back up again? I know that the Premier is very interested in that matter there. And how do we do it in such a way that we don't go out and then all of a sudden we're right back to where we were about 4 or 6 weeks ago and we have to go back in? That's even more costly for businesses in that sense. So we're hoping to do some very careful planning with our public health measures table, looking at what things can we turn the dial back on, at the same time keeping our guard up on a different way to deal with things in the future. If you think back of how we were 6 months ago, we were doing a lot of things, but hygiene, personal hygiene, infectious disease things was not very much on the minds of the public. The public have moved into a different phase in thinking, and they have invested in this really well. If we're going to go forward, how do we keep that going and return a lot of things to functionality so that we haven't let our guard down, but we haven't limited things so much that we are suffering not only economic consequences, but there's other things like getting our healthcare system back up and running, people seeing their physicians again. All these things are very important, and we can't delay too long, but we don't want to have to go there and then all of a sudden we're right back in, hospitals filled up and intensive care units. No one wants that. The Premier doesn't want that. Our Minister doesn't want that. And I don't think the citizens of Ontario want that. And I don't want that.
Next question.
Your next question comes from Salman Faruqi with the Canadian Press. Please go ahead.
Hi there. So we've also seen that the growth rate of the virus today is at 5.1%, which I believe is the lowest that we've seen in weeks. I was wondering if you can confirm if that's true and how much we can read into that fact.
So, yeah, that's another statistic that's very interesting is the growth rate, and we've been doing that at the federal, provincial, territorial level, looking at the pan-Canadian numbers, and they were peaked back about 12 or 13% back in about the 8th of April. So we've seen that growth rate coming down across Canada, and Ontario included. So that's encouraging. Even with our rate of positivity, we talked about that of our lab tests, with our lab specimen data, that percent has even come down by a full percent, down to 8% from 9. We were up, as I said, around 12 or 13%. So that's steadily coming down. That means the people coming forward with symptoms, sometimes mixed with allergy and different things like that, a smaller and smaller percentage of them are positive. And that's encouraging. That means the distancing of things have limited the spread. And then we talk about other fancy data points called R-naughts. And we're going to be looking at that to see how are we doing Ontario-wide, how are we doing regionally, and is that going to help us in some of our decision-making? So all positive good signs that we're moving in the right direction, and we're hoping to hear some further details on that from the modelers on Monday.
Follow-up?
Okay, and excuse me, this has been asked earlier, and I also posed this question to the Premier. But with the numbers improving and some optimism voiced from officials throughout Canada this week, people are going to be wondering when those restrictions can be loosened, but also if there's any sort of specifics about what the loosening restrictions could actually look like, what sort of measures could be rolled back. And I was wondering if you have any specifics on that.
So, yeah, and what I said before, our community numbers, we're coasting the mid-200s, upper 200s. I'd like that to get down a bit further. I really think it can move down fairly steadily over the next number of days. We have had our assessment centers open up to a wider, any symptom at all, and we widen our definition, remember? So we're going to get a lot of people that may seem with that are COVID, but they're not. That means our positivity rate will keep dropping further, and so we want to see those numbers go down. That means if you have 230, 250, 60 still reporting daily out there, there's still a fair amount of movement. If we get that number down low enough that we can do very much targeted case containment, that means on a go-forward basis, we can keep that number under control and not have spread wide in the community. Why is that important? If you think about it, like even with directions with schools, if it's not a widespread community and you put the schools back together, we've worked hard to keep the children free of infection, and you reintroduce it back in again into a naive population, then you've only just taken 5 steps back. So we're trying to look at that very carefully, along with the Minister of Education, and how to look at that. We're looking at other things. What are essential? Like being able to see primary care physician again. How would you do your office a bit differently? Can you have a waiting room filled with 30, 40 people for 2 hours? The answer is no, but we don't need to. We have other things to do. So it's going to be like we can resume we had the critical services, the essential services, and now the necessary services. Can you do it in such a way that you can maintain the physical distancing? Can you maintain the personal hygiene in that sense? And I think we've seen our industries and companies become very creative, and we've seen a lot of the virtual aspect really being enhanced. And so we're going to be looking at those things as we can and deal with it by case, and trying to move as, I would say, steadily towards opening up more and more and more. But it's going to be, as I said, the term is yes, but you have to do this and this. Yes, but you need this in place. Yes, but you have to be cautious. And I think that's probably our modus for the next number of months, even into the fall. We're going to be doing a lot of yes, but you have to remember. And that's going to be an important ongoing message.
Next question.
Your next question comes from Sneh Dugal with Queen's Park Briefing. Please go ahead.
Hi, Dr. Williams. Thanks for taking our questions. Hopefully I didn't miss this, but I'm wondering if you could just provide the number of deaths that are related to long-term care in terms of the 36 new deaths in the province.
So in the IFAS system, the ones that have been recorded with all the data inputs into the epidemiological database called IFAS, that number, we said there is the 36. Some of those in there are complete. The long-term care home said that the actual number of deaths that they reported since yesterday was 44. Now that's administrative data. That means all the other epidemiological materials that need to be attached to those cases has to be taken through and fed through the various public health units to get into the data system, to be entered, to come forward. So we know it's somewhere between 36 and 44. The administrative staff said 44. Now, were they all COVID positive? We think so. We've had some where they may say there's 44 deaths and there's testing pending. So does that mean it was a death or not a death due to COVID? After a day or two, they put that in. And then someone said, well, then we put that as a new death. They say, well, no, it was already a death. So that kind of cleansing that goes into the IFAS system is different than the administration data. Did they report that, 44? They did. So long-term care yesterday in the ministry, we said in long-term care homes that they feel are related to COVID, they had 44.
Follow-up?
Okay, thank you. And yes, I'm going to try and pack a lot into this question, okay. But I was also wondering about communal dining in seniors' homes. I know there's some homes without outbreaks that are providing meals to residents in their rooms, and others are still having residents dining together. Have you issued any guidance on this at the provincial level? And if you are still allowing homes with no outbreaks to have communal dining, I'm just wondering why not preemptively require that homes instead provide residents with meals in their rooms, considering the risks and the spread that's occurring in these facilities.
And we're talking about long-term care facilities, correct?
Long-term care and retirement homes.
Oh, Okay, so there's going to be two different answers. I forgot to mention, I said there was 44 deaths, and of course there was the one staff death. And I was more remiss in not saying that, and that was unfortunate, and then we didn't want to forget that. So just so I clarified that point. So in the long-term care facilities, they're different than retirement homes. And in the long-term care facilities where they have had no outbreaks, like some parts in other parts of Ontario, they sometimes have where they have 2 or 3 people together, because you may have one PSW needing to assist in feeding 3 or 4 people. They don't usually put them in a room with, say, 300. They have little hubs and stuff like that, and they try to limit that. That's why when we said if you have an early symptomatic patient in a long-term care home, we not only want to test that person, the staff who are mostly assigned to work with those people, but also if there was 2 or 3 others in their hub that were having times close together, they could deal with that. So there's some need to have that kind of activity as well as some social connectivity. They're probably not putting them right shoulder to shoulder. They're about 6 feet apart. So there's various ways they undertake to do that to not only give the proper care, but also some social contact, because they don't want them locked in the room if there's no outbreak. If there's an outbreak, it's a different thing. Then you're going to put people and separate them out in the rooms, and you're going to reduce that. That's part of the infection prevention control practice. If you have separate rooms, and even now we're trying to look at moving patients out of the 4 plexes into 2 plexes, if not, and even further if we can. So these are steps taken. Retirement homes, on the other hand, are places where individuals live independently to a certain extent in their own apartment, whether it's a 1-bedroom or 1 room or whatever. They sometimes they buy the purposes of the local setting to eat in a dining room. Some may allow them to go down the dining room. I hear they're spacing them, so they're not 4 clustered on a table. They're sitting at separate tables. Different retirement homes are doing different things. Some are choosing to say, I'd rather have my food in my room. And some do actually do their own cooking in the room, then they get groceries and things delivered. So retirement homes are quite different than long-term care homes, and there's a wide variety of retirement homes. So there's not one simple answer for either. If there's an outbreak in a retirement home, as we've seen in the past with flu, they're usually told to stay in the rooms. They have the meals in the room, and they do some different processes to limit the contact among the among the residents. So long-term care, different than retirement homes.
Next question, it'll be our last.
Your final question comes from Mo Fahim with Vista Radio. Please go ahead.
Hi, good afternoon, Dr. Williams. My question is, Toronto Public Health is reporting 3,145 cases as of, I think, afternoon yesterday, April 17th. And I'm looking at the epidemiological report for Ontario that came out as of 4 p.m. April 17th, and it says Toronto cases were 2,800 and I'm looking at it right now, 45, I think, 61. Do you mind explaining what that discrepancy? I'm reading in the report. It says that because Toronto transitioned to another system, there might be a discrepancy, but that's almost a 200 case number discrepancy.
Mm-hmm. So Toronto Public Health, because of their volume and number of outbreaks, and as I said, they have about 50% of the cases, so they have a huge workload. And to put all that into the integrated public health information system, because it's while it's a bit of an older system, it has its challenges. And if you're bringing a lot of new people in, it's a fair amount of a learning curve to get them to understand the idiosyncrasies of the system, if you may. And so what they decide to do, because they have the IT type staffing, to bring in another system that has its own way of collecting all the key data, and they have said we would think it's better because we can do it quicker in that way, and the main data points we can export into IFAS, and they had give us full guarantee they can do that. So they did their first run on that, and for the most part it was successful. If you take a percent basis, there's still some that didn't get transferred over, and they're going to modify and rectify and deal with those accordingly. So there may be a delay in it coming in, but anytime you deal with these new systems, these IT solutions, they all have to be dealt with correctly. In the end, is the data going to the system. Is it accurate? Is it correct? And is it timely? And that's the goal that they're going for, and that's the aspect we said we'll work with you on that, and the main thing we want is the data that's correct and accurate and comprehensive in the right way in the right time. If you want to use a system that does that and can import it correctly, let's do it. And so they've done their first phase and had a little bit of a stumble, but I think they'll correct that fairly quickly.
Follow-up, and this is the last question.
So just to be clear, that stumble was that stumble that did the stumble result in an increase in numbers? And if it didn't, why? If it did, I guess then it would account for 284 new cases, which kind of pushes the new total Ontario case number to 769. Wouldn't that number affect kind of like the modeling?
What is a delay in moving them in? So we got a 24-hour delay. My number is different than 200, but let's not talk about the details. That kind of number will be rectified and moved in. The modelers actually won't be looking at the data from today anyways. They're looking at from yesterday, and they did all their work already. So they're looking at trend directions, and timeliness of data coming in doesn't change the trend direction as long as it gets in, and that's why you don't do it like up to the minute, because there's a lot of data cleansing and to make sure the data is accurate. So in that system, I don't have any problems with that being the modeling. Any data system has its limitations and aspects. You have to understand that. What you want to know is, what does it tell you what's going on, and how do you put that in? That's what the modelers want to know. And so when we look at that, we make sure it's clear. The issue they had with the number will come out correct anyways, because if it was that some of the cases they had, they didn't get imported correctly, all they have to do is make sure they're imported correctly, and that'll be rectified as soon as they solve that problem. It's all part of the implementation process. So I'm not perplexed by that. It's the same as in delaying getting lab tests from this group over to that group. In the end, the lab tests will get done, and we'll get the correct data. I'm more interested in the accuracy of the data, not just its utility, or for its utility purposes, not just for the sake of having data for the sake of data.
Thank you very